Good afternoon, everybody. My name is Deborah DeBruin, and I direct the Center for Bioethics at the University of Minnesota. And I want to thank you all for joining us today for our ethics grand rounds. This is going to be a really interesting session, and I'm really excited to be able to have the center bring Dr. Eckenwiler to all of you. Let's begin. Before I introduce Dr. Eckenwiler, let me begin with some logistics for today. Next slide, please. Thanks. So for the discussion period at the end of the talk, please use the Q&A function that you'll find at the bottom of your screen to type in questions. And if you'd like to follow up on a question once it's been answered, feel free to use the Q&A function for that as well. You can also use the Q&A function. It's a one-stop shop if you're having technical difficulties, and center staff will address those privately with you using that function. Let me say, if questions, if you're formulating questions in your mind during the talk, feel free to enter them in the Q&A at any time. You don't have to wait till the talk is over to type in your questions. Just feel free to enter them there at any time. I should note for folks that today's event is being recorded. The recording will be available on the center's website at the URL you see there on the slide within a few days. There is also a presentation details document that center staff will link in the chat today that will provide you with all of these logistic details. We would request that you consider filling out an evaluation for today's event, if you would. The center takes feedback on ethics grand rounds and all of our events very seriously, and we're really interested in hearing your reactions to this and your suggestions for future planning. So we'd appreciate you taking a few minutes to fill out the evaluation. As you can see from the slide, there are 3 ways to access it. It will automatically pop up in your web browser after the event to make it really simple to fill it out quickly as soon as the event is over. If you don't want to fill it out right then or don't have time, feel free to just click out. It's also linked in the presentation details document that you can find in the chat, and you'll receive an email after the event. So if you want to go back in later and complete it, that's fine as well. We appreciate your consideration for providing us with feedback. Next slide, please. So there are a few types of credit available linked to today's event. For University of Minnesota students who have active status in health professions programs, this event has been approved for interprofessional education credit. If you'd like to pursue IPE credit, please complete the reflection form that's linked in that presentation details document that you can find in the chat, and that will get submitted to us, and we'll be able to let the IPE team know that you've received credit for today's talk. If you'd like to request a certificate of attendance for CEUs, please complete the form that's linked in the presentation details document. It might take us a few days to get those certificates issued to you, but we'll do that as quickly as we can. And I should note that based on the rules, not of the center, but of the accrediting agencies, you have to attend at least 75% of today's talk in order to receive a certificate. Finally, biomedical engineering students, in order to get ethics credit for attendance at today's talk, please email your program. The email address is linked both on the slide that's displaying right now and in the presentation details document for your convenience. Next slide, please. I'd also like to thank our co-sponsors. Those of you who regularly attend ethics grand rounds know that we partner with other programs at the university to bring you every single ethics grand rounds presentation that we host. And I am grateful for the partnership that that we had the privilege of securing for today's talk. So I'd like to thank the Center for Global Health and Social Responsibility here at the university, the medical school, the School of Public Health, and the School of Nursing. Next slide, please. Finally, without further ado, I would like to introduce to you Dr. Lisa Eckenwiler. We are so delighted that she is here with us today. As in keeping with our normal practice, I'm going to give just a very, very brief introduction. There's a fuller bio for Dr. Eckenwiler in the presentation details document and on the center's website. Dr. Eckenwiler is professor and chair of the Department of Philosophy at George Mason University. Her research centers broadly on vulnerability and structural health injustice, with special interests in migration, humanitarian health ethics, and placemaking. She's here today to talk with us about an eco-structural approach to health ethics. This should be a fascinating discussion. Dr. Eckenwiler, at this point, I'm going to turn it over to you.
Thank you very much, Dr. de Bruin. It feels funny saying that since I've known you since I was just a wee graduate student, PhD candidate. But here we are in our advanced ages, if not advanced careers. Right, I mean advanced, but not toward the terminal end of things. So thank you so much for hosting me this afternoon. I really want to thank Deb in particular, Dr. de Bruin, for being really patient, because she's been inviting me for a while. I've been putting her off for a while. Things have just been a little busy on my end. So I'm really grateful for the opportunity and also the patience. And thanks to Kayleen and Leanne and the rest of the team there, who I know helps land the planes and do all of the things, to make all of this happen, and also to the sponsors. I told folks at the beginning, I hope one day that I can visit you all in person. My nephew lives in Minneapolis, and his fiance is a PhD student there at the University of Minnesota in neuroscience. So part of my heart is right there in Minneapolis with you all. And I've got, some nice friends, including Dr. de Bruin. So it's nice to see you in any form, in any modality. But one of these days, maybe it will be live and I can, go swim in your Minnesota lakes. I seem to have not come in a pleasant time of year yet. We'll see what happens. It's okay. I have the same problem. I have a lot of colleagues in Montreal. I don't know. So with that, let me go ahead and share my screen. How's that? Okay. It's not the slideshow view, but can you see it?
We can see your slides. You are not in slideshow view yet.
Got it. Okay. All right. There we go. Good.
Now it is perfect.
Okay, so terrific. So what I want to present today is something I've been sort of developing over the course of the last several years. And it's sort of coming together, I think, in what I want to argue for is sort of an approach to health ethics writ large. That is bioethics as we understand it in its sort of traditional domains of patient care, not so much research ethics, but perhaps there too, public health ethics and global health ethics. Let me start with one of my favorite stories that kind of, brings together not all, but many of the ideas that I want to talk about here. So quoting Michael Kimmelman, one of my favorite writers in the New York Times, who writes about architecture, the kerfuffle started when word spread that the police were repeatedly evicting elderly Korean patrons from a McDonald's in Queens. It seems that the Koreans were milking their stays over $9 coffees and violating the restaurant's 20-minute dining limit. The police, things got really heated when the police were brought, right, to evict them. And they were, ultimately escorted out, and they said, but wait, this is where we like to come. We enjoy the big windows. We can look out and see what's happening on the street. We enjoy the sunshine that comes through. We come here together to sort of, meet up with our friends who live in the neighborhood. We're able to walk here from our apartments. We call up our friends back in Korea. And we think this is a really important, place for maintaining our community. And part of the frustration with the community had to do with the fact, let's see, there you go, that they had offered them a place to meet in the basement of this Korean cultural center. And they said, look, we'll even provide you with transportation. We've got a van. We'll pick you up at a certain time every day. We'll drop you off. We'll pick you up, take you back, right? What's not to like? And they say, well, thanks so much, but we are not school children or government workers. We want to see our friends where and when we choose. So it's a little bit of a lighthearted example, but what I want to try to capture with it, at least initially, is this idea that we are really best understood as what I want to call ecological subjects following Lorraine Code, but also been described as maybe placelings. So quoting some philosophers here, we are never without emplaced experiences. Human beings, along with other entities on earth, are ineluctably place-bound. To be is to be in relation to place. Or Lorraine Code, the person who really I draw the most inspiration from in my own work, says, we are made by and making our relations in, I insert, a symmetrical reciprocity with other subjects and also with other multiple and diverse locations. So it isn't just interdependence that feminists, communitarians, and lots of other folks have recognized as critical to our possibilities, but also our locatedness. So in sum, what I want to start with is this notion that we are really best thought of as ecological subjects. That is, we are embodied and we're embedded both geoatmospherically and also in social structures, in what I want to call, following other folks, health ecosystems. And also to think about ourselves as really radically, profoundly interdependent, not just with other people, but also with places through natural, historic, and also social transnational processes. So again, a little more inspiration here, in addition to Lorraine Code. Some of this comes from the work that's been going on in the last couple of decades in social epidemiology. People like Nancy Krieger, for example, have done incredible research on the ways in which place and place-related features matter for health. Similarly, the Lancet Commission on the Social Determinants of Health Inequalities, back in 2005, under the leadership of Michael Marmot, talked about the profound importance of societal determinants of health, including place-related features in what I would call, following other folks like Sridhar Venkatapuram, the capability to be healthy, or health justice, in other words. Also informing my thinking here is work in moral philosophy, especially in justice, and especially in what I want to call relational conceptions of justice, which recognize relationships between people, histories, places, and the like. And this is beyond the scope of what I can talk about today, but I'm just gesturing toward it here as sort of informing the argument I want to make. So a couple of people especially important here. And I know Dr. De Bruin knows this work really well from Iris Young, because it's informed some of the work I know she's done as well, on women's inclusion in clinical trials. Both of us, I think, cut some of our early teeth on thinking about conceptions of justice and the inclusion of women in research projects. Anyway, so Iris Marion Young has this important argument about structural injustice, where she says, look, when people are making claims of injustice, they're not just saying there aren't enough resources to go around. They're saying something more profound about how they're situated within social processes and structures. So the definition of structural injustice following Young is when social processes so think social norms, think stereotypes, think economic structures, put large categories of people under a systematic threat of domination or deprivation of the means to develop and exercise their capacities, at the same time as these same processes enable others to dominate or have a wider range of opportunities for developing and exercising their capacities. So we take the same idea and then we think about what is its relation to health and health justice, or the capability to be healthy. And so following the line of a lot of folks thinking about this, Rioa Chung, University of Montreal, has coined this term structural health vulnerabilities to try to point toward the intersection of structural injustice and health injustice. So she defines it in the following way: an increased propensity to incur health risks and potentially health injustice or systematic threats to the capability to be healthy directly related to social inequalities that stem from structural and epistemic injustices. I can say more about what that is in a bit, that affect an individual or a social group. So thinking about how are people situated both socially and how are they situated in terms of social structures is informing the idea here. So an eco-structural approach and how it pays attention to health ecosystems, or in other words, places. I want to suggest this happens in two respects. Some of you who've studied philosophy may recognize this term situatedness. And it's not really been used to talk about our geographic or spatial location, but really more how are we situated socially. But I want to combine these two things and say this account pays attention to place or situatedness in these two ways: atmospheric, geographical, and also thinking about how we're located or situated amid social structures. So as we're looking at health ecosystems, and when I'm talking about health ecosystems, I mean, I need social epidemiologists to help here. But the idea is we can map these in a couple of ways. We map them in terms of location. So this could be neighborhood, this could be workplace, it could be home, it could be a clinical setting. And we also want to think about, and we might even think about patient groups, for example, as another way of mapping a health ecosystem, like people with chronic pain, right? Just, or people with long COVID. I think there are many different ways we could think about mapping this with, people who are better than I am as a philosopher and thinking about that. But then also, how are people situated in terms of social structures? So, are they vulnerable to social stereotypes, economic injustice, exploitation, and so on? So it gives us at least two kinds of questions to ask when we're thinking about how do we promote the capability to be healthy for people. First of all, the social within the ecosystems that they dwell in, and I hasten to add, right, there are multiple ones that are intersecting for all of us. So do the social conditions within the places that we navigate enhance the capability of individuals, communities, people with a cluster of symptoms, or in a certain socioeconomic situation, however we're mapping it, to be healthy? And do the conditions there generate, sustain, or deepen structural health and justice? So the approach tries to acknowledge all the while that we're radically relational in terms of with one another, with multiple places, and also in relation, we live in relation to social structures. Just, in even kind of Buddhist ways, right? That nothing is fixed. We are not fixed. Places are not fixed. Health conditions are, ever fluid. And also thinking about, social power and injustice, and particular places of fragility within ecosystems. Okay, so concrete examples of what I'm talking about. How do we deploy this way of thinking in healthcare, long-term care, public health, and global health? So some examples. So in a healthcare context, this is a neonatal intensive care unit in Bath, England, that is, I think, really interesting, particularly from the design perspective, because it gives attention to the places where families and really vulnerable newborns and healthcare providers are interacting together all of the time, thinking about the lights, the sounds, the smells, and how people move around in the space. So you've got, on one part of the slide, the kind of map of the way the thing is built, which is striking because it shows how you're going to get out of there. It's literally a clinical pathway. So rather than being kind of labyrinth, overwhelming, confusing, right, like a lot of clinical settings can be, and I know we're doing better, but, here's somebody who's given really careful attention to place in terms of like the spatial design bit. Also, part of what they try to do, right, is organize spaces so that there's more natural light, so that there's more places for people to sort of sit and talk, so that care providers, family members, and care providers, everybody can interact more, have more conversation, and just, be around and be comfortable more. And so far as I know, there isn't data that's come out of this yet that said like, oh, we have better patient outcomes. But when surveyed, people say, oh yeah, that was a much better experience than the usual sort of NICU experience, particularly for, well, maybe exclusively for, who knows, family members. Long-term care, another, and this is really kind of where I started this, in terms of origin stories. I was thinking about, I took care of my grandmother in a couple of decades ago. And I thought I was going to start working on family caregiving and ethical issues there. And like, why is this my job? Why am I doing this? And sort of distributive justice and family caregiving issues. But it turned out to be sort of a project about global justice and the sourcing of the long-term care workforce. So more of that in a bit. But in terms of design, again, thinking about place and placemaking. So the greenhouse project, this little thumbnail here, is a project that is in New York, where basically people are in long-term care facilities that are houses that exist within neighborhoods. So people can walk to markets and they don't feel like they're in a kind of an institutional setting. And so and I think there are multiple examples of that kind of thing at this point around the country. Then this middle slide that shows the sky. This is the Davis Hospice in Wyoming. And what's really cool about this, it's on the high plains. And what they've tried to do is create here a wind garden, thinking about the importance of wind to the people who come from this community, and, open sky, open spaces, and, just being part of the natural environment and the way that it looks and sounds. And I guess that's it too, with the cathedral ceiling and the library cozy armchairs. Toward the bottom, the three photos down here are an example or come from a long-term care setting in the Netherlands called Hojwe Village. And this one's really interesting because it's designed, as the name would suggest, to be like a village. So people live in what looks like a house or an apartment connected to other houses and apartments. They have markets where they can go do, with the assistance of a caregiver, grocery shopping. The interactions with care providers don't always look like interactions with care providers, or like, monitoring their vitals, for example. Like people will be shelling beans and at the same time. So trying to demedicalize the environment. The other thing that they give really careful attention to is mobility. So it's designed so that people can go outside, people can walk around. There's also a lot going on in terms of relationships between that enables family caregivers to have a better relationship with staff and the place itself, so that they're not always having to drive back and forth if they live long distances. Again, there's attention to place there in that people aren't having to navigate long distances to try to see their loved ones. Now, thinking about the structural injustice bit here, and thinking about relationships between different people, and thinking about relationships between people and place. The other thing that an eco-structural approach enables us to do, not just thinking about design, right, and how that supports the capability to be healthy for elderly people. What about what that place was for other people historically, right? So where Davis Hospice is located, sitting, right on what was, areas of Indian removal once upon a time. So we want to think about, like, well, what's the relationship between these elderly people and the elderly people who are displaced from that location and relocated on reservations where their mobility was constrained, where their access to health services was pretty radically diminished, and where, health indicators are about as poor as they get in the United States. Two, the eco-structural approach lets us think about, as I suggested at the beginning, thinking about long-term care, the sourcing of the workforce, right? So we get, in high-income countries, a substantial share of not just our nursing workforce, but also the long-term care workforce, like paraprofessionals, home care aides, nursing aides, from low-income countries with very high burdens of disease, also significant aging populations, and inadequate health infrastructure. So we want to think about the relationship between these people, those places, and the capability to be healthy around the world. Public health examples. So this, the giraffe path comes from New York City. So many great examples in New York. Some of you may be familiar with the work of Mindy Thompson-Fullilove, who's a psychiatrist, who was, and maybe still is, based at Columbia and the School of Public Health there. And she studied African-American populations as if they have PTSD, and tried to make, and found links between urban planning policies and long-standing health inequities. So urban planning policies, for example, serial displacement and relocation. So lots of rezoning, urban planning has constantly disrupted African-American communities. So, maybe, I grew up in Tulsa, Oklahoma, right? And so many of you may know about the race massacre of 1921, where this whole entire community was literally burned to the ground. And so, the people who had funeral parlors, hair salons, magazine and newspaper stores, markets, cigar stores, right? Constantly relocating, right? Those same people may relocate and then, there's going to be urban renewal and they're going to move again. Or my personal favorite is intentional shrinkage, where developers decide that they're interested in an area. So what the urban planners do with the assistance of city council is sort of defund the police, the fire departments. So when things start to burn, they burn all the way, and then you got to go in and rebuild, and those people have moved out. So she's studied those kinds of planning policies and the way that they're related to things like obesity, addiction, HIV and AIDS. And this new initiative with the giraffe path has been looking at the relationship between those communities in New York who were displaced and cut off literally from crossing this bridge, whereas the other side of the bridge, what became a very affluent community, full of nice parks and beautiful schools. So Mindy Thompson-Fullilove, some urban planners working in New York City created this thing, the giraffe path, as a way to reconnect what had been fragmented parts of the city. Plus, it's a biking cycling path that anybody and everybody can use. So they talk about it as a victory for the city's entire circulatory system. And at the same time, part of what it aims to do is to respond to longstanding health inequities that have affected African-American communities. This example comes from Colombia and Bogota and Medellin. And what they've done is create what they call blocks of care. So located within particularly vulnerable communities, and maybe this is a place where there are a lot of migrants or other low-income communities, or people who have come in from rural areas and are moving into urban ones. And it's sort of like, it's like the Walmart of care services. So you have nutritional insecurity, there's a place for food. You need help to take care of your grandmother, there's help there. You need translation services, there's help for that. You need referral for mental health services, there's somebody to see and referral there. And there's this map, sorry, it's really fuzzy, but the idea is, again, multiple pathways, and the environment itself is pleasant, not one that a lot of people who are who suffer structural health vulnerabilities are kind of used to inhabiting. One other point here, I guess, about the structural bit, structural injustice. Part of what these blocks of care exist to do is provide particular support for women who are dealing with gender-based violence, something that they don't necessarily have very well addressed when they access medical care providers in more typical settings. And also, as I think I mentioned, there's a lot of attention to immigration and the vulnerabilities that recent migrants may have suffered. And I think some of that knowledge gets taken back to trying to inform health and other kinds of social policy. It's really interesting. Some of what's happening in cities, as you all know, is better than what's happening at national government levels in terms of support for migrants. Another area I've got particular interest in is humanitarian health. So it doesn't really take a lot of explanation to appreciate that where people, the settings that people dwell in humanitarian context are, very much like prisons. There's a recent book by Kelly Oliver, philosopher at by University of Minnesota Press, I hasten to add, that's called Carceral Humanitarianism, which just really homes in on the fact that people are segregated, isolated, cut off from not just access to work, but access to pretty much anything in really deprived environments. So it's not a big stretch to think about the implications for the capability to be healthy for these people, particularly thinking about the fact that now displacement is protracted. And people will be often in humanitarian settings for multiple generations, not just in, the Gaza Strip, but in Lebanon and Jordan, and a lot of the Syrian refugees and Afghan refugees will face a similar plight, right? Or people already been in Greece for the better part of a decade and unable to get any farther. So thinking about place, UNHCR, UN High Commission on Refugees, is trying to rethink the way they've been providing what they called shelter and are now talking about in terms of accommodation for people. So in short, moving away from this idea of long-term, moving away from this idea that people are going to be here temporarily and providing them sort of what some people call liquid disposable kinds of provisions. And also getting away from the idea that, so people won't be there temporarily. They may be there a long time, but if they are there a long time, you don't want to be thinking about a long-term care. You want to be thinking about how to support people's dignity and support self-determination, which I think we want to understand really carefully. We could talk more about that if you'd like, but I worry a lot about self-reliance as a notion that we want to, call upon refugees to realize. But in any case, trying to respect people's capacity for autonomy, and thinking more about what kinds of conditions they live in and what are the conditions for their lives going forward. And then there are some really interesting architects who I'm calling cosmopolitan architects, both because they're, thinking in global terms, but they're also thinking very much about global justice. And they've got some really innovative ideas about how to redesign humanitarian settings. And I'll just cut to the last one. Baalbek Bureau is an architecture firm founded by a refugee, and is now working in the Ukraine on this modular town system, which is like a construction kit that you can adapt to different types of terrain. You can use it for like healthcare, like clinical kinds of settings. You could use it for schools, you can use it for homes. And they also try to find ways to make it sort of like culturally relevant. So it isn't just like, here's your tent, here's your space blanket, the usual story. Let me see how I'm doing on that time isn't working. Let me give you one other example that I really like that's very specific to healthcare that didn't make it to the slide. So a colleague of mine, Aisha Ahmad, who's at St. George's University in London, has done work on gender-based violence. And what she's done in particular with her colleagues who have worked in safe houses in Afghanistan, they've called for a rethinking of the kind of mental health intervention that these women get, if they get anything at all. So usually they would get nothing, but if they get something, it's like, go talk to the psychologist, along the lines of a very biomedical model, sort of, cognitive behavior therapy. So talk about the violence that will, reduce your maladaptive cognitive response. So instead of that kind of approach, what they've done is design a narrative intervention where the women together talk about stories, both like cultural stories that come from their families, their communities, and together kind of weave stories that integrate their experience of violence, but in a communal way, so that it's sort of like transformative of identity. And at the same time, what they're trying to do is transform social structures that make gender-based violence a norm. So away from the biomedical model and thinking about how does this intervention fit, how do we deal with gender-based violence in a more culturally appropriate context, and at the same time be critical of the gender norms that put women in this context or in this position of vulnerability in the first place. Something that sort of Western psychiatric approaches tend not to do as well. So another way of thinking about place. So like I did with the long-term care example, I'd like to think about, on an eco-structural approach, relationships between places. So like there are different kinds of gated communities. I've got family members who live in gated communities that look something like the thing on the top. And then, here we've got an image of the US southern border. And then over here, a picture of, I've forgotten whether it's Manus or Nauru, one of the islands where people who arrive by boat to Australia are literally kept in cages. So, what is the relationship between these people and these places? And what are the implications for global health justice? Okay, last example, I believe. Thinking about us as ecological subjects and what's between a public health and a global health approach, something like a trans-regional, transnational approach that would fit within this eco-structural approach I'm trying to argue for. So some of you may know about One Health, a should I call it a movement, I guess, and sort of an approach to global health that tries to look at the relationship between people and their animals, in addition to the relationship between people and the environment. So here the idea is to think about regional health with a focus on the Tijuana River Valley, which has lots of birds and other wildlife and antibiotic resistant bacteria, sewage, disease carrying mosquitoes. And so what I think is interesting here is it looks at health as a transborder phenomenon. So think about, again, health ecosystem here. It's probably the clearest example of that, involving not just humans as the focal point, but the relationship between humans, animals, and the environment. So how do built environments and population health interact within this regional biography and ecosystems of particular places? So what I like about this is it's not just individuals and populations that's the focus, but biogeography and water flow paths. Okay, so summing it up, why do I think an eco-structural approach for health ethics is a good idea? Well, first of all, I think it enables seeing who and what we are more fully. And that is really profoundly relational creatures. Relational, like in the sense that if I sneeze on you, you might get my cold, but also in the sense that we need each other to survive, but also in the sense that there's a relationship between all of us and the native people who used to live on the land that our universities occupy, and a relationship between us and people in low-income countries whose children may be taking care of our grandmothers, leaving them, to go it alone, or, to deal with some kind of complicated, diverse family system of care, dispersed family system of care. Also thinking about, how we're related to place and different places, and how we're related to bats and mosquitoes and birds, I think is really going to be essential if we're going to make it out alive. And if, COVID has taught us anything, I hope it's that. Also, it helps address an overemphasis and overinvestment on biomedical commodities, things like vaccines, which are great, but they're not going to save the day over and over and over, and an underinvestment on social determinants of health. It identifies links between structural injustice and health inequities, what I described as structural health vulnerabilities here. And that's also useful for assigning responsibilities. So, who is it who's responsible for supporting people's capability to be healthy? And I'm not making that argument here. I'm just saying it's another way that an eco-structural approach can do mapping of responsibilities for health injustice. It attends to the fragmentation of the healthcare system, like the multiple forms you have to fill out if you go to more than one kind of a provider, or if, heaven forbid, you're taking care of somebody old and they need, to see multiple different kinds of doctors. But also the fragmentation between healthcare system and public health, US and other places, and that the environment is sort of over here as an afterthought. It also, thinking from a global perspective, challenges, I think, methodological nationalism in the organization of healthcare systems. In other words, we fend for ourselves and we expect all the other countries to fend for themselves, which is radically cynical because we rely upon workforce from other people. And those other countries often subsidize that workforce. So, the people who are nationalists, I think, are less lucid than they might be in thinking actually about what supports healthcare systems around the world. And that's the migration of health workers, among other things. So, what would it look like if we thought about relationships between health ecosystems? And what would it look like, for example, if we mapped health ecosystems at a global level and we deployed health workers according to the needs in particular health ecosystems, instead of country by country by country by country, where the rich people do better than the not rich people. Also advances epistemic justice, that is, supports fairness in giving more respect to the people who suffer structured health vulnerabilities and health injustice as generators of knowledge for how to respond to that problem. So while now, we would say doctors and global health, um, from Boston who work in, Sierra Leone, maybe, um, have epistemic privilege. They're the ones regarded as the knowers, the experts. And there's a pretty robust critique of that at this point, especially on the global health front. And so I think part of what an eco-structural approach can do is say, well, we help people with structural health vulnerabilities map the health ecosystems, and we help inform, we ask them to help us understand what it is, that are the needs and the priorities there. And then finally, it holds potential for redistributing it holds potential for redistributing value to other forms of life and what a philosopher Jane Bennett calls vital matter. So I'm not going to sit here and argue for what people call bio-egalitarianism, which says, let's displace the humans as the privileged species. I'm not prepared to go there yet, but I think there's a lot to think about in terms of the need to redistribute value so that we are perhaps less privileged than we are now in terms of what we focus on when it comes to questions about promoting health. And that is that. Thank you so much for your attention.
Thank you for that. You have given us so much to think about here. This is a really ambitious view, and I was scribbling down notes. And you and I would have a long conversation if it was just us, but I want to make sure that we get to the questions that other folks are raising here as well. The first question that came in, the question came in as I was typing this note to myself. You were talking about the connection between health and place and urban planning and the kind of health impacts of urban planning, and that example of the giraffe path. We have our own example here in the metro area, as I think many metro areas do, as you alluded to, right? The Rondo neighborhood that was in St. Paul, that was a thriving, predominantly African-American Black neighborhood, BIPOC neighborhood in St. Paul, that was really damaged, ripped asunder essentially by the building of Interstate 94,
Right.
straight through the neighborhood in St. Paul. And lots of conversations now about rebuilding Rondo and land bridges and so on. I think the questioner actually provided a link to the example. It's the question under the answered section. Here's a local example of reconnecting neighborhoods, and you see the reconnecting Rondo link. That I think is a really interesting example. And I don't know if you want to comment more on those sorts of urban examples. I think they are not, it's not like Rondo is a one-off, right? Yeah. So do you want to comment more on the connection of the pervasiveness of that and the connection of that to health in that broad sense?
Yeah, I mean, I think what's really, to me, what's interesting about those examples in particular is that it shows the disconnect between the way we think about who does work in health, and
Yes.
so it's not just, what I love about these examples is it's architects, designers, urban planners talking to public health people, because these are sort of regrettable, to say the least, barriers that we've created between disciplines that really make it harder, if what
Yeah.
we're trying to do is support people's capability to be healthy. So I think part of it is like, what's great about the social determinants of health examples, right, is it shows you've got to have integrated knowledge, you've got to have transdisciplinary thinking about this stuff. And those are great examples, the urban planning examples. And they're also great examples, right, because they I mean, they bring it all together. They bring together health injustice, the history of health inequity, and the way that that's done by policy, and it happens in a place. And the way that place related deprivation, right? And people don't see it as connected to policy. They see it as
Yes.
like, well, these people are lazy. They're not working. They don't take care of their stuff, but you don't see the underfunded fire department. The other good example of that, right? I mean, where Dr. Drew and I met, Chicago, right? Cabrini Green and all the deaths in the heat wave. And like, why did all the Black people in the towers die? And none of the people in the Latino community died. Same weather, different kinds of neighborhoods, different kinds of histories, different relationships to injustice, right? So you had one community that's totally connected socially, lived on the ground in like not high rises built by urban planners, and they were able to go around and talk to each other. Whereas you've got like the disconnected Black people in the towers, literally baking to death and afraid to go out because they're afraid of getting beat up. They're afraid to like walk out their hallway, get in an elevator, because of the conditions of public housing back once upon a time. I mean, Cabrini Green doesn't even exist anymore. It's been all gentrified. That's another question. That's another issue, but not unrelated. But that's another really interesting example of urban place and capability to be healthy in totally different communities. Same natural phenomenon, like in heat, natural phenomenon, but one, right, like shaped by social structures. So, like you've all read the article, Denaturalizing Disaster. There's an example of, there is no natural disaster. Yes, there could be a heat event, but it doesn't have to be a disaster. It's because of choices humans make. That's what leads to the disaster. I mean, the other example of that, right, and I digress, is Haiti, right? It's like, yeah. Okay, so a tsunami hit, but it's not the tsunami that's the only problem there, right? All of the things that happen with humanitarian agencies and so on, that creates the disaster too. So I hope that gets at it. But I think, those urban planning examples are great because they show social determinants of health and the need for transdisciplinarity in responding to health injustice.
Yeah. So there's just so much to think about here. And I just want to follow up quickly. One quick comment, and then another invitation for you to explore the connection between this and one of the other things that you said in the talk. So the quick comment is, I mean, this is an event that health profession students can get interprofessional education credit for, right? And I think this is just a great example of how interdisciplinary and transdisciplinary work on ethics, work on public health, work on healthcare really needs to be in order for us to fully understand what the influences on health are and how to better promote health and well-being, right? So, I mean, I think this is probably rarely the case in the academic health center that we think about urban planning.
Right. Well, I mean, everything happens before people show up at the academic health center.
Right. Yeah.
And what
That's
happens
fair.
when they leave there? I
Right.
mean, and I mean, like I said earlier, I started in long-term care, because I was taking care of my grandmother. And that is such a fascinating example because it's both like a place where people live, and it's a place, hospitals too, right? Like, no, it's a place where people live a long, long time. And it's a place where people work.
Yeah.
So it's both a care setting and it's a workplace, right? So it's like that relationship between place. So and there are organizations for this, like better jobs, better care, better working conditions, better care conditions. Duh, But then what about the relationship between this place and some long-term care facility in the Philippines that's like understaffed and under-resourced, and so it's like, what's the relationship between these people and their capability to be healthy? Her nurse's grandma, and like the nurse and me, like this is a better job for the nurse than what she would have had in the Philippines, probably. But I'm going off to my oh so privileged, Department of Philosophy job. I'm still in a better position than she is. Right. So it's like all of these relationships between people and identity and place, like that's where, I saw like the interconnections of these things was, doing this care for my grandma. It was like, it wasn't just like why I was going to write about why I was mad at my family members for not helping me out. There was a lot more going on to the story there, like about this woman's grandma and the relationship between me and this woman who was like cleaning, my grandma's room and doing her laundry. And I was taking my grandma to lunch on Sunday and to the doctor's appointments and doing a lot and stressing a lot, but I wasn't cleaning the bathroom.
Yeah. I want to invite you to close the loop on then the point that you made in the talk about how the connection between all of this and responsibility or assignations of responsibility.
That's the hard one, right? So there are two things going on. I want to say eco-structural approach is helpful for kind of health ethics in general. Like everybody would benefit when you're having a baby, when you're going to get your kidney stones removed, when you're, dying. We would all do better, if we use this eco-structural approach. I think that the biggest selling point for me is that it helps address the people vulnerable to health injustice, right? Who either don't have the capability to be healthy or who, struggle with the capability to be healthy. And so remind me the question again, right? So like responsibilities. Yeah. So part of it is just like for all of us trying to promote ethics in health related settings. I want to say there's a way of seeing people and a way of seeing what they need, right? That is improved if we have an eco-structural approach. But when it comes to health justice, right, there the critical thing is to try to address the structural injustice that threatens the capability to be healthy for those particular populations. So what I see it as being able to do, are things that seem kind of like low level, like improve like what our experience is as patients, as family members going to see patients, as people who need public health services, right? Or who are thinking about public health and urban planning, right? Like, how do we use this approach to try to move away from the biomedical model, the behavioral model, right? And say, well, a lot of this is about social injustice. And that's where the work is. And so then who's responsible, right, for the injustice? So if we're thinking about public health, right? And so I think the short and simple answer is all of us, right? But I think it's multi-level. So, there are things for which government is responsible because government has the greatest capacity, and also governments, made policy choices. But we are also government. That means there's collective responsibility here. That at other like individual people, in other words. But then there's like this institutional level responsibility. So, hospitals should be thinking about like, well, what's it like in here for somebody dying? Or what's it like in here for, people who are grieving somebody dying. And so there's that level of responsibility. But then, like for urban planning, it's like, well, whoever's responsible for serial, relocation or serial displacement, right? That means government's responsible for addressing the health inequities that resulted from that. I think, if we're thinking about global health or Native people's health, I mean, I would argue for, I'm committed to relational ideas of justice. In other words, if you're related to the injustice that people suffer, then you have responsibility. So, Iris Marion Young, if I go buy clothes at the Gap that were produced by a low-wage woman, like a woman making low wages who's in crappy working conditions that might be unsafe, I'm partly responsible for her plight. Like, I didn't set the wages, and it's not my fault that she lives there and I live here, but indirectly, circuitously, at a distance, I contribute to the injustice that she suffers. So I'm responsible at that level, right? But then government's also responsible for those workplace conditions that make her unhealthy. My government's responsible for the workplace conditions that make her unhealthy, right? Because it's making all kinds of trade deals. So multi-level responsibility. So government, if we're talking global health, it could also be international lenders have responsibility. I mean, that's part of the reason why the out migration of health workers is because of international lending policy and what that's done to healthcare systems in low income countries. So I didn't choose it, but I live in a democracy. I vote for people. They choose those policies. They benefit me because I can buy cheap clothes. I can buy cheap drugs. I benefit from importation of healthcare workers for higher wages, right? So multi-level responsibility, depending upon how you're situated within the social structures. So we have all got power. This is straight up Iris Young, right? You assign responsibility based on your connection to the injustice and your scope of power, basically. So I'm not a government, but I could think really hard, for example, about my choices in life, and where I buy my clothes or how I choose to take care of my grandmother or how I treat the person who takes care of my grandmother. But I can advocate for fair immigration policy. But then when it comes to immigration policy, well, that's government level. So so that's a relational justice argument, but I think you can make utilitarian arguments. I think they're probably human rights arguments. I'm not a big rights person, but I think they're human rights arguments you could make about this, in terms of having a right to the capability to be healthy. And there too, right? Like, who's responsible for upholding human rights? Usually it's governments. So more investment in all of the things. So at the government level, I would put it like this: more investment in all of the things that are part of the eco-structural model. So place, making sure that the conditions that people dwell in geographically, atmospherically, are conditions that allow for them to be healthy. And also paying attention to the kinds of social norms, stereotyping, and economic structures that people end up embodying.
So if I can sort of jump in here, because there are some questions in the Q&A about economic structures, and one in particular sort of captures some of the ideas that are coming up in some of them. The questioner says that they love the more holistic perspective. There are some other questions about the holistic perspective we'll get to, but this says it has some intersection with the movement toward a more regenerative economy, because part of the issue is economic inequities, of course, as you were just commenting. And then the issue is another questioner raises the question about the intersection of this with what gets referred to as donut economics, that it's all relational.
Right.
So,
Yeah. So like even the well-off people are badly affected by inequities, in other words. Is that the idea?
I'm not sure, but it is true that well-off people are badly affected by um, um, sort of people with privilege who live in cultures or societies that have greater degrees of inequality have less good health outcomes.
Yeah.
Right. Yeah. I mean, that
And so that's
levels
it
of
at the end of the
inequality in a
day.
society do impact health outcomes. Yeah. Not,
Yeah.
yes. Even though obviously the more privileged people do better than less privileged people do
At the end
because
of
of
the
the
day, you
social.
can go to the enlightened self-interest argument always. I don't really like to go there, but I will.
Yeah.
If there's nothing left.
Well, but there's plenty else left given everything else that you've said. So the to think about then that more sort of holistic perspective, a few people have raised questions about the sort of connection between this and the sort of perspective of indigenous communities and how they conceptualize health, that sort of and sort of approaches to knowledge in indigenous communities. There's also a question that's gotten raised about, let me see if I can find it again, about maybe you just want, oh, queer ecology.
Yeah. Okay. So I'll take a little bit of stab at that. I don't know anything about queer ecology. It's new to me. I have a book on my shelf, so I'm interested. And when I was talking with Dr. DeBruin before this seminar or the webinar started, I said, I just went to a conference in the spring where I got introduced to what I think is linked to queer ecology, and that's arboreal feminism. So it's like, thinking about being and existence more from the perspective, and even ethics from the perspective of a tree, basically. It might seem absurd, it might seem really profound to you, but it made a lot of sense if you're coming at it from kind of feminist commitments to ontology, which says like, well, we're relational creatures. So so I don't know about queer ecology. I also am not at all competent to say anything about Native American or indigenous people's philosophy of any kind. But my sense is that in terms of what we in philosophy would call ontology, like what are we as creatures, I think there's a lot in common there, right? So it's away from thinking in terms of individualism, and instead thinking about like profound relationality, also thinking not just about relationships with other humans, but thinking about relationships with other forms of life, and maybe not even forms of life. I'm not so clear on what Native people understand in terms of life, but I know that things like stones have spirit, right? So even maybe life extends to that. So I think like ontologically there's a lot of relationship between what I've said here about ecological subjects and I think what like indigenous philosophies would have to say. Sort of linked to that is the thinking of another philosopher I've just been reading. His name is Achille Mbembe, and he's got a couple books out: Critique of Black Reason, and then Necropolitics. And so he's a Francophone philosopher working on like decolonial thinking. And so I've been thinking about him in the context of global health justice. And he's got really interesting ideas about, well, he talks about African philosophy and how African philosophy would not see us as Western philosophy does as being, like capital B, as individuals, right? But instead, it's relational from like all the way through. And not just relational in terms of relational with other people, but relational again with like other, other things inhabiting the earth, that have life or spirit or something like that. And profound relationships between people across great distances just because of the slave trade and other, histories of colonization and just global interchange. So he's like, we are all fragments of a greater whole. The other way may be that it's, and again, I'm stretching here. The other way maybe it's related is thinking about the epistemology piece, like who's seen as a credible producer of knowledge. So when I said the thing about health ecosystems being the kind of thing, like epidemiologists might say, well, I know exactly how to map that. But I say, be cautious, right? And let the people who are suffering structural health vulnerabilities start the mapping. And do the work of identifying needs and priorities. So when we talk about epistemic injustice, we talk about, the credibility economy and some people not being treated fairly in the credibility economy. So I think part of what a connection here is to say Native people and other, groups who faced historic injustice are where we start our thinking about the capability to be healthy, and what's needed, in terms of place, whether like locationally or in terms of social structures. So I think I see a connection, in that respect, privileging the knowledge of the people, with the lived experience.
Thank you. So another question raises issues around sort of the work of Van Rensselaer Potter. And this questioner says the link between ecology in the broader sense and bioethics is not new.
Good.
And that a landmark in the field is the work of Van Rensselaer Potter. And the questioner wonders how your eco-structural approach relates to that work. Yeah.
Okay, thank you so much for that question. And you're right, I need to do more of a hat tip to him. So full disclosure, I graduated from the University of Wisconsin-Madison as an undergrad, which is where I believe he was also a faculty member. So but yes, I think one of the big problems in bioethics, the US version of it, is that strand of the field pretty much got lopped off somewhere until maybe Hurricane Katrina. Then people started thinking like, oh, climate, health, ethics. But I think that's absolutely right? That bioethics, that's part of the origin of the field. Like when I teach the class to my undergrads, to our undergrads, it's like there's the Georgetown thing and there's the University of Wisconsin thing.
Yeah.
And this is the one that took off. Why might that be so? I invite them to think about that, but we don't spend much time there. But then there's this whole other thing now that's been more influential in Europe, but not so much here. So I do not know his work intimately. I know that he was thinking about more population health than individual health. And I know he was thinking about the relationship between the health of the earth, the health of the environment, and the health of people. And that's about as much as and thinking more like, upstream causes. That's about as much as I know of his work. But I absolutely think about people like Aldo Leopold, Sand County Almanac, that stuff as being, and it was Wendell Berry, like all of that is, very much, if I were ever going to write a book about this, all of this stuff would be cited in it. So I really appreciate that. And I need to do more. Like, he's not a direct influence, but I should totally acknowledge his work in the field. For me, the person, I really came at it kind of from feminist philosophy. It was like Lorraine Code and her work on ecological thinking coming together with Iris Marion Young. So for me, it was like ecological epistemology, like thinking about relations between places and people and knowledges and health, and then structural injustice. So it was like that mixtape, it's kind of where I've ended up. But absolutely, his work has been so important, and I think needs to get more attention as, like, sources of thinking in bioethics.
Thank you. Unfortunately, we're out of time. Quite sure how that happened
It's so
because this
fun.
went by so quickly. And I want to apologize to all the folks who raised questions in the Q&A that we did not get to, but I do really want to take another moment to thank you before we sign off. I really appreciate your taking the time, because I know you have a very busy schedule, to join us here today and to share your work with us. And we look forward to seeing more of it in publication. And I see that Kayleen has just posted the presentation's details document in the chat again for people's reference, so that you have that, folks in the audience. And what I will say to you all is, the people who have joined us here today, thanks for taking the time, and watch for information about the spring series for Ethics Grand Rounds and for our Unpacking Bedside Bioethics. So thanks very much, everybody. See you next semester.
Thanks for coming. Thanks for having me.